Dear Heavenly Father, as we gather here today for our committee meetings, we ask that you put your hand over us to make the right decisions. We ask you to bless our people, bless the troops overseas and here in the United States. We ask all this in Christ's name. Amen.
Amen. Next on the agenda is roll call. Please acknowledge that you are here.
Bradley Cobb.
Aye.
Janelle Fulbright. Bill Anglin.
Here.
Bill John Baker.
Here.
Jack Baker.
Here.
Harley Buzzer.
Here.
Julia Coates. Here. Joe Crittenden.
Here.
Jody Fishinghawk. Here. Meredith Rayleigh. Here. Don Garvin. Hannah Laura Jordan. Present. Chuck Hoskin Jr.
Here.
Curtis Snell.
Here.
Chris Soap.
Here.
David Thornton. Kara Cowan Watts.
Next on the agenda is the approval of the September 16th regular session minutes.
I move they be approved.
Second.
We have a first and second. All those in favor say aye.
Aye.
Any opposed? Motion carried. And next on the agenda reports, and up first, Marty Smith from Claremore Service Units. You are the next contestant.
Good morning, everyone.
Morning.
One of the things that on the first listing that I mentioned as an accomplishment this month is our visits. I'll go over it in more detail at the end of the report, but the September visits were up, and that's good for us at this point in time, since we've seen a few months of them being down. As far as the future plans or new initiatives, I listed one. There's actually 2 or 3 more that we're going to engage in, but this automated appointment reminder system I think will be good for the patients and also good for us, because it should help eliminate a lot of missed appointments, which will improve the productivity of our providers also. I don't know an exact date that we'll get this installed, but I'm pretty sure we'll be able to achieve it before the end of the year. As far as announcements, we have a new surgeon that came on September the 15th, Dr. Stephen Katz, and we also I listed 3 nurse midwives. Dr. Mobley corrected me earlier this morning. We actually, I believe, have 4 nurse midwives that have committed. This will help us tremendously in the OB department towards getting the department fully staffed. As you know, we got the chief of service came on board the first week in September, so if everything goes as planned, hopefully we will have that department fully staffed by the end of the year. And we've struggled with getting the bathrooms, I've mentioned it before, completed in the labor and delivery rooms. But they're scheduled, we have contractors scheduled to start the replumbing and retiling of those bathrooms on October the 26th. At which time we'll start a fairly aggressive marketing effort to try to make up for some of the service that the patients have received in the last year in that department. Try to let them know the changes that they made, both in the rooms and in the program itself, the model of health care that we'll be using in that area. We're having a drive-through clinic. It's actually more of a parking lot flu shot clinic. We did it last year, and we got a lot of positive comments from it. We'll also, along with that, of course, we've tried to make it as easy as possible so that when the patients want a flu shot only, they don't have to endure a long waiting period when they walk into the hospital to come in and get a flu shot. So hopefully we have the mechanisms in place to make that as easy as possible for the patients. We have some visitors from the Inspector General's office. This is part of their annual plan. They're scheduled, I think, in Oklahoma at our facility and at Lawton's. I don't know at this point how long they will be there. They don't know. They don't really know. It could be anywhere from a few days to a few weeks to a few months. But what they will be looking at is like an audit of, when I say the pharmacy department, I'm talking mainly about inventory control, both of narcotics and legend drugs, the prescription drugs, and they'll follow it all the way through the chain of receiving and dispensing and administering in different areas of the hospital, that type of thing. And then they told me this is unusual, but they're doing 2 audits at the same time. The same group of auditors will be looking at if you're a healthcare provider involved with care of anyone under 18, you're supposed to have this background investigation performed before you come to work or shortly thereafter, and they'll be looking at how well we're doing with that as compared to other facilities and that type of thing. I'll try to keep you updated on that. As far as our visit workloads, I think I mentioned at the last meeting, it might be a good idea if I start showing shorter time frames, because hopefully as we get the hospitals staffed adequately, get a staffing level of primary care providers like physicians, hopefully our visits will improve and our patient access to care will improve and the waiting time will improve. So I took a look at just September in addition to the year-to-date figures, and September's visits are up, and outpatient visits are up 21%. The admissions are up 18%, and the newborns 28%. Overall, our visit count for the year to date, that would be October through September the 30th, was down approximately 9% for the year. And following visits, of course, is collections. I did some, our collections, I did a graph to both show you how the visits for September look, but also on page 4 of my report, I did a graph on collections to kind of show you where we were at. We finished up with like $11.1 million, less than we would have liked to have had. Encouraging news, once again, with September. I was talking to Dr. Mobley about this earlier. Our September collections were not real high. Our September billing was $1.9 million. So it would be logical to assume that next month we'll see a significantly increased number of collections as a result of what was billed in September. As you know, the CHS activities have been closed due to the end of the fiscal year. And on the total number of visits, we're still in the process of this week we'll be getting the final count on visits, and we'll also get the reconciliation. It looks like that we finished the year in the black. we will, of course, when I report to you next, I'll have exact numbers on that also. One of the other things that we're looking at doing is, I think it was mentioned, is to increase the number of benefits coordinators. What happened as a result of that was I had a meeting with our ambulatory care manager and business office manager. And one of the things that we determined from that meeting is that our benefits coordinators are not strategically located appropriately within the hospital. And we also realize that all of our new patients never get channeled through a benefits coordinator. So we are going to try to relocate those coordinators and try to also see that each new patient registering at the hospital at least has the opportunity to visit with the benefits coordinator to see if they qualify for any resources. And kind of a collateral project that we're looking at involves the ER area of the hospital, because we still do not have 24/7 registration. So when people come through the ER at night, we're looking at when we alter the flow back there, putting a benefits coordinator back in that area also, so that when the people come through at night, they'll have the opportunity to, sometimes in emergencies that's not the optimal time to do that, but it's also a good time when they enter the system. It's our only opportunity to assist them with benefits coordinators. And now on the very last page of my handout, I put this there just mainly for informational purposes, but right now the number of patients that we actually have, that we show that have alternate resources, is around 36%. And so hopefully of our entire patient population, so hopefully that is an area that we can, if there is any room for improvement in terms of identifying patients that qualify for resources, that's an area which we can address also with the relocation.
Have any questions, Councilor Butler?
A couple of questions and comments, Marty, on your alternate resources. How are you finding that out?
Well, primarily through registration. As the patient checks in, they should be asking them each time. And of course, that's my job, I guess, ultimately, is to monitor how good a job they're doing at doing that. One of the things we're looking at doing too is kind of shifting who puts that information in, because on new patients or with resources, if the registration people collect it, they're often, you probably have seen those lines, and they're trying to keep people from waiting an extravagant amount of time to register. But as they collect the information, it's equally as important to get it put in the system in a timely fashion. And we're looking at allowing registration to collect it and billing people to put it in, because they have more ownership in seeing that it gets in there. But equally as important as collecting it and getting it in there is being sure that what you have in there hasn't changed. So it really has to be addressed each time the patient registers, or checks in.
And I just think these benefit coordinators that you're talking about, I think those are really, really important.
They are. And
I could see a benefit coordinator being right there at registration, because that's where you're going to catch the people. Because if you got a benefit coordinator sitting back down the hall in an office, what good, what purpose are they doing down there? Unless somebody actually tells those people to go down there and talk to the benefit coordinator. Those benefit coordinators have got to come and talk to the patients. Patients are not going to go down and talk to that center.
That's one of the very first things, like I say, that when we engaged in looking at the number of benefits coordinators, was the fact that we weren't optimally using the ones we
They're going
had.
to be worth their money, that's the dang good. I agree. Thank you. Thank you.
Councilor Hoskin.
When a patient has a contract health claim denied and they file the appeal in Oklahoma City, does Claremore get a notification that that appeal has been filed? Do they get a copy of the appeal?
You know, I personally don't see those, but I'm sure that the contract health department does. But
So Claremore could track, if Oklahoma City is communicating back to Claremore, Claremore would know if an appeal was filed.
you should.
And then you would subsequently know if it was denied and get a copy of that denial, or obviously if it was approved, you know that.
We should, but I'll confirm that. But I mean, we should be getting those.
Okay, thank you.
Councilor Soap.
Yeah, Marty, on this contract health services, looks like you're saying that you had $8.6 million that was allocated for 08, and you expended all that. And so, of this 11.1 that you designated that was denied, and then the 2.9 million of unmet needs, does that include any contract services that they were denied because the Cherokee Nation might be paying for some of them, or is that totally just 14 million? Is that funds that you just don't have available right now?
That's really, that's the part of it that I notice. Well, I guess to answer the question, that's money that we don't have. That's if we could meet the needs that came through. If we met every need that come through, you're right. We would require.
But in your data, are you including information or dollars that maybe the Cherokee Nation? Okay, so you don't. That's all unmet or denied claims. It's 14 million. Okay. The other question I have is that whenever somebody comes in to compete for contract health services, what type of notification procedures do you give the patient that they've been approved for those services? Some of the feedback that I've received is that they might be approved, these patients, but they don't really, nobody's informing them, or they don't know that they've been approved, so they might be worrying about it for a little while, or just kind of unknown.
Well,
so what's that process? Can you explain it to me?
Well, they should get an approval letter, just like they would if they got a denial letter. But I guess once again, it's all, unfortunately, a lot of that is based on, in addition to our staff doing what they're supposed to be doing, it's based on how accurate is the information that we have on addresses and phone numbers and that sort of thing in our registration. Anytime anyone is not sure, I would advise them to call and talk to our director of the contract health services, and then if we're still not, if for some reason they're not getting a response, which I think they will now, but if for some reason they're not, then it would, I would advise them to call me.
Timeline 2 weeks after the application, or what's the decision?
Well, usually, Dr. Motley,
It's by Friday, they get the way that works is our department tries to get them an appointment, and they call them by Friday that week. Sometimes it may go on to Monday.
Okay, so is it a phone call or is it a letter? Is that both maybe? Or?
A lot of times the patients are calling back themselves if it's something they feel is urgent, and they'll say, well, call back Friday, and the patients actually will call back, so we set up their appointment for them.
So once you get the application, it's usually 1 week
Or less.
before somebody knows that it's either been approved, denied, or postponed.
The committee meets, in fact, it meets today, and then they'll start processing in the afternoon, and tomorrow they'll start sending out letters and also calls to tell them, about their appointment. And a lot of times they'll have the patient that has been processed, they'll have them call back. It's easier for the patient to call back, find out when their appointment is with them. So it's more or less a weekly cycle.
Councilor Callan Watts.
Thank you, Mr. Chair. When you have new folks come in and register and they bring in their cards and stuff, how do they verify tribal citizenship, or do we just accept on face value that those cards are accurate and true?
You know, I'm probably, my belief on that is that they probably accept the card and they require like a photo ID also, a copy of a photo ID.
If I'd like to go query to see if an individual has utilized the Indian Health Service system, or I think if it was a tribal entity, I would have to go to that tribe if I thought a clinic was near them and they'd faked a card. But if it's Indian Health Service, can you pull up if I was served by Woke? I have to go to that individual clinic to find out then. I can't just go, there's not a central database for Indian Health Service. I thought that's what it was, but I have to confirm. Okay, thank you, Mr. Chair.
Any more questions? I have a quick question. And I'm not putting you on the spot here, but last time we met, it was essentially a year after this new council, and I've been looking at your reports. And one of my concerns was the visits were down, the collections were down, everything was down. And this month, everything's up. So, what do you attribute that? Do you attribute that to? Are you using different software? Do you feel like you're seeing more people? What do you mean? The numbers. I'm looking at a medical practice, and I'm looking at your numbers going up in the 30% range in 1 month.
Well, you know,
I'm just curious. What do you attribute that to?
Well, you know, as with anything, you can never just look at 1 month, and so you know, it's like someone asked me about earlier about you know, our occupancy rate. Well, you know, in the summer it's way down, and in the winter it's way up. And which month is it going to be this year that it's going to be full? I can tell you it'll probably be somewhere between mid-November and the 1st of March, but I don't know which month. So really, I'm hoping, you know, obviously that some of our efforts towards improving provider productivity and just the sheer numbers of staff, you know, as I have said all along, in January we were down nearly 36% of our staff, and those are the people that see patients. So even though we still see patients and still see appointments, we haven't been able to see as many patients and haven't been able to make as many appointments. So hopefully as we see our staffing, the OB department is probably the best example. I mean, basically the OB department was put on hold for 6 months, and we weren't allowed to staff. And I'm pretty confident that when we get it fully staffed and providing a service that's good for the patients, we'll start seeing the patients return. But we have, you know, they are customers, and we have to earn their business. You know, the same way if we have extravagant waiting times, some of those patients that have insurance are going to go somewhere else, so we have to provide them the same service that they can.
I think we talked about this last time. I think you kind of hit it on the head. Unfortunately, you're in the unenviable position of you're competing in a market that's a little bit different.
It is different.
You're competing in a private medical facility market, and you're a federal health facility, and so it's going to take a little bit of creative engineering. One of the questions also I have is how many staff actually do you have that's doing coding and I'm just curious. I mean, and the reason I'm asking is essentially your collections have essentially remained flat. They've kind of done this. I'm just curious. many people do you, as you know as well as I do, keeping up on Medicare allowables every year and coding and submission of bills to insurance companies is a game, unfortunately.
Well, it is.
Complicated game.
And it is, and that whole process has been real dynamic in the last couple of years because who used to be coders are not, 2 years ago, or say 3 years ago, we had coders and they did all the coding. And we had billers that did all the billing. And now the way it works is there's been a huge shift over the last 2 years to where the coders are the doctors now and nurses. And the coders actually provide oversight for the coding that the doctors and nurses have done through the electronic health record. And so the only area that they're really coding per se would be visits through the emergency room and a few isolated areas within the hospital. But and then once again the shift in billing has changed because 3 years ago the billing people did all the billing, but now they're more like accounts receivable people because once the record is released from the medical records department through the coding queue, it's pretty much a done deal. So, but to answer your original question about how many staff there are, I want, ballpark figure, I want to say 20, but I don't know the exact number. I'd have to check on that.
Well, and I think, as you know, I'm always amazed that when I'm looking at coding, you're exactly right. It's kind of turned into where the doctors are the ones, before that patient leaves the room, needs to code that billing correctly. And I can see in my own practice, the money, if you don't break, the key phrase now is breaking all the charges out. And if you don't break those charges out correctly, so, I was just curious as
it kind of
you have any kind of in-service for the docs.
Well,
unfortunately, I know we all hate that, but
we do constantly. But one of the things that I bring it up again because it's real timely is once again with contract doctors, if you're not staffed adequately, you have the upfront loss of productivity because they're coming into a strange environment. They're using software they've never used. And how many weeks or days, weeks or months does it take for that provider to become good on an electronic medical record and be productive with coding? So hopefully as the staff stabilizes, you'll see all of those parameters stabilize or improve, I should say.
Good. Are there any more questions? Thank you. And next under new business, or actually next under reports, is Melissa Gower of Cherokee Nation Health Services.
Good morning, everyone.
Good morning.
First, I apologize that I had some handouts today. I know that you want those 10 days in advance, but unfortunately, I received those yesterday, and I was out of the office yesterday. So from this point forward, they will be included as a part of your overall health packet that I send 10 days in advance. Cherokee Nation Health, we received numerous GPRA awards this year, and GPRA stands for Government Performance and Results Act, which is quality healthcare indicators that we measure our healthcare system with, and we received numerous, probably 13 awards in that area this year, so we're very proud of that. Muskogee Clinic, J Clinic, Salina, Nowata, Bonita, and Bartlesville all received awards. A couple of other highlights is that the drive-through flu shot will be, I think Marty said in Claremore, October 20th through 25th. At Hastings, it will be November 3rd, 7 to 7 a.m. to 4 p.m., November 4th, 5th, and 6th, 7 a.m. to 6 p.m., November 7th, 7 a.m. till noon. So I know you all get lots of questions and calls about drive-through clinics, so we'll have those two areas going on. Claremore and Hastings are doing that. Currently, there are 3,126 patients enrolled in the Hastings Pharmacy Refills by Mail program. We're continuing to work on looking at that, expanding that into all of our health facilities in our area. Over the last couple of weeks, we've been doing a lot of training for employees at Hastings on lots of different things, from our Lawson system to our HR system to manager trainings to all different kinds of things. So that's been doing very well. Christine Gillum, who is the Survey Readiness Officer in Performance Improvement, is the first professional in Oklahoma that has this certification and is currently only one of 54 in the whole nation. And so we're very proud of Christine for her achievement. Also, a couple of things at Hastings is that we're in the process of reorganizing the housekeeping department there. That's going very well, getting them some new equipment to be able to take care of their duties. We've got the dining room going there. We've gotten very good results from that. Lots of positive feedback from having a place where staff and guests can get something to eat while they're there. That's gone very well. We continue, we're doing an analysis on that and continue to work on plans to expand that a bit. We also have installed audio-visual sets in the pediatric waiting area for all of the children that are there waiting on their medical appointments. October 17th, how many golfers do we have? A few, I know. Is the annual Powwow Golf Classic at Cherokee Hills Golf Course in Catoosa. The Women's Health Fair is this Friday in the dining room at Hastings from 9 to 12. Our cancer survivors dinner is October the 25th at NSU. I also gave you a copy of the Cherokee Nation Health Services Healthy Nation program, which is a school leadership award program. I gave this to you last year, and I'm bringing it to you this year so you can, we've sent it, of course, to all the schools and have all of our health educators out talking to the schools about it, but just in case you wanted a copy of the RFP and wanted to get that out to the schools, I've enclosed that in your packet also.
Councilman Watt?
Thank you. Exactly who in the school would you have sent it to? Do you use, I mean, because we have a problem still, at least in Rogers County, where folks, the information doesn't get to the people that would be invested in it to actually get it done and champion it. It kind of gets lost. I can find out for sure, but I would suppose that it's the principal. Could I just get it electronically so I can distribute it to my internal contacts? Sure. Thank you. And will there be a news release on all the, sooner rather than later, on the drives for the flu shots? Yes. Okay, thanks.
Councilor Jordan?
Melissa, will you also send that to me on
Sure.
email? And then I have a couple other questions.
Also, this is in your packet. It's a Champions of Health, and I gave you a copy of that because I wanted you to see that Cherokee Health Partners, which is the nuclear imaging that we are 51% ownership in with Tahlequah City Hospital, actually won an award this year. And I was privileged enough to get to go to that, and Dr. Grimm and I both attended, and it was a very nice award ceremony, and we were very honored to be a part of that and winning that award. So I wanted you to have the brochure that was handed out there. Dr. Grimm and I went around afterwards gathering them up from people's places so we could bring you all a copy. So when you leave things behind, we're out there gathering them up, so that's okay. It didn't get lost. And then just a couple things on Cherokee Elder Care. Passed you out a marketing packet that has a lot of good information in it about the PACE program. We also, in July, just some updates. In July, provided information to various individuals, community, and state, and evaluated 4 participants, enrolled 2, and you can see in your little report all the activities, marketing activities that went on in the PACE program for July, for August, for September, and then for the first couple of weeks in October after the marketing plan was approved by the state. Actually, mail postcards out to residents in all of the serving zip codes, which was about 40,000 people, and I got one in the mail. So I'm sure if you lived in our catchment area for Cherokee Elder Care, you received one in the mail. And then I understand that you previously had gotten a copy of the marketing plan, and just a couple of comments on that. One is that on the first page of the marketing plan, it shows the enrollment goals for the first 3 or 4 years for Cherokee Elder Care. The break-even point is estimated around 40 enrollees, which is our goal for the end of year 1 of actual operation. The marketing plan and all the associated materials had to be pre-approved by the state and by CMS. You have to remember this is a very regulated program by CMS. CMS had 45 days to approve. The state had no time limit. The original marketing plan submitted with the original application was a very high-level plan that didn't have any specific content in it. So that's why that we submitted a revised plan, which is the current copy that you have, and submitted that to the state in early July, and it was approved on September 18th. So that's why all of the marketing activities happened between September the 18th and to currently. Mailed out 40,000 postcards on October the 2nd. Radio and newspaper ads were started in various newspapers and radio stations in the service area in the week of September the 22nd. And we continue to execute the remainder of the marketing plan. And just a couple of comments, and I can say these from the heart because I've tried to go through this process lately, but the Cherokee Elder Care enrollment process is a very complex process, and it takes time to implement that process because it is a very regulated program. Just to give some examples, the potential enrollee must first meet 4 federal criteria, and Cherokee Elder Care must authenticate that through the State Department of Human Services, and must verify that Medicare and Medicaid status, ensure the need of our provided level of care through what we call a UCAT assessment, check current services provided, and then we conduct a 3-day assessment consisting of a 1-day trial visit to the center, 2 days of individual assessments from the doctor, clinic nurse, physical therapy, occupational therapy, social worker, dietitian, activities director, home health, and adult day health nurse. Those people then will come together and develop a personalized plan of care to present to the individual and to the individual's family. And that has to then be accepted by the individual And once that's done, then we can enroll them in the Cherokee Elder Care through the state system. All of that has to be completed by the 14th of the month in order for the participant to begin the first of the next month. And that's important because it's a capitated rate through CMS, so if they're on Medicare and Medicaid, they have to be able to stop that and then start in this other process. So there's a processing time for the state to do that. And a participant can only start and stop on the first day of the month. So there's lots of timelines and regulations that bound that program. But despite that, the program is doing very well. I've heard some very positive. I went down one day and visited and talked to a couple of the participants, and they're very excited and have made tremendous progress just in the 30 days they've been there. So it's a real exciting program, and we look forward to its completion. And that's the end of my report.
Councilor Jordan, you're up
I'm
first.
sorry I was a little bit longer today.
Well, you were just talking about one of the programs I want to ask about. On this little Cherokee Elder Care program, summary, I guess, marketing activity report, am I reading this right? Do we still just have 3 participants?
Yes.
2 in July.
I think there's 4 more in the process.
4 in the process. Do we know how many of those might be Cherokee?
Of the 3, I think 2 are Cherokee and 1 is non-Indian. I'll verify that, but I think that's what it is.
What about the 4 that's coming in?
I don't know that until
And
they
I know they
meet
can't
it.
discriminate,
Mhm.
but we did send $750,000
That's right.
over there.
I am very well aware of that.
I'd like to see how much that's costing per Indian client.
Absolutely.
Okay. The other thing I wanted to ask about was, I guess Ed doesn't do the report anymore, but his report was submitted to us, and I would assume that's your report now.
It will be, and that will be included in the one that I send you 10 days in advance next week.
Okay.
He
Yeah.
just didn't get it to me in time this time.
On that report, I see where we have 43 staff retirements in September from Hastings Hospital. Were we able to pick up any of those on the
Yes.
travel side?
The majority of those retired and then came a travel hire.
You don't happen to have any idea?
No, I don't have the exact breakdown, but I know at least 4 totally retired. I can probably get that number for you.
If you would.
But I know the majority of them just chose to retire and then became a travel
Would you
hire.
make that a part of your continuing report too, so that we can see if those retirements go up,
Sure.
where they're transitioning over to us or going somewhere else, or what's happening to that experience?
Sure.
And then the third thing, I noticed in your program highlights where we talk about Hastings, that in July, when we unveiled the plans for the 45-acre site, we have that it includes a 200,000 square foot healthcare facility. But I did not see such facility in the comprehensive health plan. And maybe the reason I didn't see it, so maybe I'm reading it wrong, is the $200,000 or 200,000 square foot healthcare facility, is that the total of all the facilities you plan to put there on that 45-acre complex? Could that be where you're getting the 200,000?
Can you tell me exactly where you're looking at so I can
I wish we
compare
could,
apples
I wish
to
at some
apples?
point we could start numbering our pages, but it's on.
Is it on my report or Hastings'
It's
report?
on your report
Okay.
under program highlights for Hastings Hospital.
Okay. Oh, that's the press release there on the
Yeah.
front? Okay.
Right, I'm just trying to get a handle and make sure now, is this 200 square foot healthcare facility, is that the total of the 5 facilities that you want to put on the 45 acres? Or is that a separate facility that is not listed in our comprehensive health care plan submitted today.
It has to be total.
Well, the reason I'm confused is you have a new surgery center also and other buildings, including, see, it's almost like with those commas, it's almost like we're gonna have a 200,000 square foot healthcare facility, then a new surgery center, then other buildings including facilities for doctors, medical storage, health programs, and services.
Right.
So I was trying to figure out if we've left something out of our health care plan that we maybe need to do some revisions today.
Okay. Couple things. One is this on the front of my report is an exact replica of the press release that went out. So that's that. On this, first of all, you know, the square footage is going to change as we do the actual planning for that program. So these aren't set in stone as far as square footage. These are estimates. I mean, if we get in there and start planning and we really need to build a hospital instead of a outpatient clinic, by the time we do, you know, we're going to have to do a POR and a PJD. I mean, it may end up being 400,000 square feet.
And that's my question.
So these are just estimates.
Okay. And that's my question. Is this 200,000 square foot healthcare facility, is that the hospital?
It's an estimate for the health facility on the Burchett property, whatever that may be.
So that's that is the 5 facilities that we plan to put on the 45 acres. It's the total of the surgery center, the warehouse, admin offices, Jack Brown.
Of the current estimate, yes.
Okay.
But that's going to change.
Okay.
I mean, I'm here to tell you, I already know that on the outpatient clinic, whether that be a clinic or whether that be a hospital, that square footage is not going to be 40,000 square feet. I mean, if it's a hospital, it's probably going to be more than that. If it's a clinic and we do a program justification document, which is a document that we do on all of our health facilities that outlines the square footage needed for those services, that's when you come up with the actual footage. These are estimates that were done on these facilities that add up to that.
Well, then my second question is, then are you asking us to embrace a health care plan that sounds like it's going to change pretty quick?
Well, what I'm asking you to do is embrace this plan so I can continue to go forward and do the actual PJD, because it's going to cost me money to do those things. I need to get in and start doing the planning on these individual items.
And I think my other questions need to be...
I mean, and then as those plans are finalized, just like Veneta, when we started Veneta, I think it started out as, the very first estimate was like 30 or 40,000, and now it's up to, I think, 70,000. And the POR should be signed off on, and PJD hopefully in the next week or two. And I don't know what the exact square footage is until it's actually signed off on. At that time, that's when I start the planning, the real planning process on trying to get the financing, on trying to get the staff from, you know, wherever I'm going to get those and place those. But just on a preliminary estimate, these are just preliminary estimates. Yes.
And I want to reserve those other questions for when we talk about the health plan.
Okay.
I have some other questions, but I have one question about the flu shots. Drive-through, does that apply to the little children too, or is it just for the adults?
Children can drive there.
Okay, so as long as we get them in there by 6 o'clock on 4th, 5th, and 6th after school, we can probably utilize the drive-through?
Yes.
Okay. Then I have one other thing, the announcement.
Do you want to do it now, or do you want to wait till announcements?
Well, I think she needs the order.
ahead.
We have a working committee and this doesn't have to do with Melissa, I'm sorry, but we have a working committee between,
Like 15
and Gail wanted to order meals for the, for that working committee through the Maryland Cochran benefit that they're having today. They have carry out, it's ham and potatoes and sound like a real good meal, and she needed a number of how many people would be staying and how many people would want her to go get a meal for us.
Can we have a show of hands of the committee
Yeah.
members?
If, of that working committee, any show of hands, who wants to have Gail go ahead and order your? 1, 2, 3, 4, 5, 6, Madam Speaker, 7, 8,
Or staff?
8 and staff.
Well, we'll let the staff add
Why don't you do about 10?
You do 10?
Well, it doesn't.
Give
a
a dozen?
dozen.
All right.
Okay, I'll go and
Okay.
Dr. Cox, I have a comment
On this?
on Melissa's report.
Right, I agree.
Oh, okay. Well, hang on a second.
I'm just trying to throw you off here.
Counselor
It
Soap,
worked.
Counselor Soap, was yours on Hastings? Also,
I
hang on.
don't know if it's on Hastings, but it is on the report.
Well, hang on a second.
Okay.
I got a bunch of other people ahead of you.
Okay.
So if it was about the meals, I was going to let you talk. Counselor Khan, watch.
On the 40,000 that you did the mail out, was that tribal citizens and you just used the database for the zip codes on the map? Or did
No,
you,
it's all, everybody that lives in those areas.
so you just use a marketing database list or something?
Yeah.
Okay, thank you.
Counselor Baker.
Yeah, and going back to what Tanya was asking about, and this is just a plan that we're talking about approving here in a little bit. Why would we not want to, and I realize you've got an outpatient clinic, but why would we not want to have a line for a new hospital?
Well, I mean, okay. When this is for initial support of this to move forward, okay? That's all I see that. Then, when we get in and start actually doing the planning for Hastings, I mean, there's several scenarios that can come out. One is that we actually need a hospital and use the current facility for an outpatient clinic and won't need an outpatient clinic.
And that's my point.
And I don't know that until we have support to be able to start doing that. I mean, if you want to change the wording on here,
Yeah.
that's fine. I don't care. All I want is support for this to start moving forward on the final planning
Let
process.
me interject. You just said change the wording. Change the wording to what?
Well, it says Burchett Health Outpatient Clinic. If we have, to me, all that means is Burchett Health Facility, whatever that is, whether it's an outpatient clinic, whether it's a hospital, whether it's, those are really the two scenarios that it could be. You could change it to say Burchett Health Facility or Health Services Facility.
Or inpatient.
Yeah, I don't care. Just as long as I know that I can go out and start planning that.
You still have the floor.
And it may be 40,000, it may be 30, it may be 90, it may be,
I just didn't want to rule out a...
yes. No, I'm fine. I'm fine with
The doctor
that.
said that's what we really need.
Absolutely.
Counselor Buzzard.
My comments, Melissa, was just on our Cherokee Elder Care Center.
Yes, sir.
And I'm surprised we've got 3 people in there, which is much paperwork that we've got to go through to do. And I know that's not your policy, that's the policy of where you get the dollars out. I just think we need to look at these new centers that we're looking at building and see how this is going to work before we ever jump into another project like this. It's just the paperwork. I think unless you've got an individual person taking care of our Cherokee people to get in them, you're never going to get Cherokee in. And I guess we do have counselors to help them go through the process.
We do. And Rick can maybe address it a little bit, but part of the census. Sorry. Okay, here's an email response. Sorry, just 1 second. Currently have 3 participants, trying to get 4 in. Today's the deadline to do that, so they're getting the 4th one in today. 4 more in, so that'd be 7, and of the 7, 4 are Cherokee.
And of the remaining
There
three,
you go.
of the remaining three, two of them are mothers of Cherokee citizens.
Only got 175 ahead.
There you go.
Well, I
Go
just,
ahead,
that
I'm
was just a
sorry.
comment, Melissa, because I hope this works. I think it's a good program, but
What I
it
was
makes it so difficult to get into the system, and I know it's not your fault.
What I was going to say is that, part of the feasibility and study process was that in Rick's program, the Advantage program, I think specifically, is a program that feeds right into it. So a lot of the paperwork for participants that are already in the Advantage program is already going to be done. So that's a real easy process. And we do have, outreach counselor, and they're really good down there to try to help you through the process. I've been checking in to a family member of mine, and even DHS has been great. And where it gets a little more difficult is if you aren't already in that system somewhere. But Rick can tell you how many people he has in that system already. So we'll get there. It's just I think it's pretty good to have 7 without even marketing.
I think it's good.
So we'll get
Reading
there.
off the list of the things you got to go through, and I thought, my goodness, I don't know if I'd want to do that to get into the system. But,
Well, I can tell you it is worth it. Of the results of the ones already in there, it's worth it.
Thank you, Dr. Stubbs.
Counselor Stubbs.
Now, this is one of the reports in the dental section, you was talking about dentures and all that. I know that's something that we talk about sometimes, but in there it said something about needed additional funds. Was that actually a forecast, or was that just a report? And since we're going to a new budgeting year, has that been resolved?
Yes.
Okay, so that's not
That's
actually a forecast, it's just...
It was his
Just a
report
report.
for the month of September,
Okay.
which is the end of the fiscal year.
Okay.
But those allocations have been made internally.
Any more questions? Counselor Jordan.
Melissa, would you be so kind as to, would you all put together a table for our community meeting Thursday night?
Yes, we will. I'm in the process. I was out Friday and Monday, so I'm in the process of getting that taken care
Be
of.
sure and invite all of your family
I will.
and bring your mother.
She's not doing very well right now, but
We'll take supper home to it. Okay?
Any more questions? Will you also add me to where you're sending that grant application in Bartlesville?
sure,
Because I need to know who's getting it.
I will do that. Does anybody else want an email copy of that?
Yes.
I'll just, can I just send it to you, Brad, and then you just distribute it?
Send it out.
Okay. Thank you.
Okay, old business, there appears to be none. New business, a resolution supporting and endorsing the Cherokee Nation Health Capital Improvement Plan. I noticed, let me write that down. I noticed on the actual resolution that Councilor Fulbright's name was not on this resolution. I'm assuming that you wanted that on there. This is a resolution supporting and endorsing Cherokee Nation Health Capital Improvement Plan. In 2001, there was Health Services completed a 15-year long-range plan. It was updated in the 2005-2006 Joint Comprehensive Planning exercise with W.W. Hastings. And it was determined that while substantial portions of the original plan have been completed, critical facility needs still exist, and the pending operation of W.W. Hastings facility by the nation presents an opportunity to renew support and commitment to overall long-range health plan.
I'd like to move to approve.
We have a first and a second to approve this. Any discussion? Councilor Baker, you have the floor.
I'd like to ask to add a friendly amendment to where it says outpatient clinic on the second page and 40,000 square foot / inpatient.
I do not accept.
We sat there with the veto message last night, and the chief specifically in his veto message, said, "I have visited with the medical staff at WWHC Hospital, and it was designed as a hospital anticipating 80% of the patients would be inpatient. Now, with the advance of medical technology, only 20% of the patients are inpatient, and the entire surgery wing should be redesigned. Should we not even consider building a new hospital and remodeling the current facility into an outpatient clinic?" And, you know, it's for planning. It's not telling them what they have to do. I ask once again to put slash, where it says inpatient, where it says outpatient slash inpatient, to give them the leeway to do what the doctors say is the best. Doesn't say they can't do it, just gives them the leeway. So I respectfully ask for a friendly amendment.
I'll have Melissa speak to it.
Okay?
I don't see any problem and would support adding, making it health outpatient or inpatient
Let's, instead of slash or.
facility is what I would say. Instead of slash, I'd just say or.
Is that your friendly amendment?
That would be my friendly amendment.
Then I will accept. Mr. Garvin?
Thank you.
We have a friendly amendment that was accepted for the, I want to make sure on the second page where it's under the very bottom of the current state at the top of the page, project, it says outpatient clinic. We're going to put outpatient or inpatient clinic. Is that correct? Okay. And that was accepted. Next, actually I have Councilor Soap is next on this.
Yeah, this on this report that was provided to us that talks about the improvement plan, and in the current state heading, there's a section in the second paragraph, third paragraph, that talks about that there were some documents that needed to be to IHS headquarters by a certain date. Could you describe that or explain that to me a little
I
bit?
can, and that date has been extended to November 30th. The process, and I kind of mentioned it a little bit before, but in a joint venture, actually for any of these, the first thing that you have to do is you have to have a program of requirements and program justification document completed. And that is a document that is 3 or 4 inches thick.
Right.
And it's a software program that you run through that,
You can put data.
and it spits out and says, it's based on user population, and it spits out and says for podiatry, you will need these many providers and this many square feet, sort of. And so you finish that document. The planner at Oklahoma City Indian Health Service office, Marjorie Rogers, helps us do those. They're very good documents, but that's configured along with IHS regulations for health facilities construction. So that is one document that was to be submitted by September 30th, and now I have a letter that's approving me until November 30th. The second thing is you have to have what's called a Sears report, which is an environmental clearance report on the land where the facility's going. That has to run in the newspaper for 30 days for public to respond to it. The 30 days finished on September 30th, and that's why I asked for an extension. That's now completed, and that's done by our Cherokee Nation Environmental Protection Commission does that, Tom Elkins group. So that's a document that has to be completed. And then the third thing is a draft copy of a joint venture agreement. And so those documents have to be submitted, plus you have to buy the land, you have to submit a copy of something showing that you have land to put the facility on.
This section mentions something that there's actually a model, which is called the chronic care model.
Mm-hmm.
What's the difference in the CCI model? What is that? stand for? Or
Okay.
How many
The-
models are there, I guess? is
Okay.
my interest.
This is the project that I've talked about, that we are one of 14 sites across the United States that is implementing. CCI stands for Chronic Care Initiative. What I use to refer it to is patient-centered care. We have implemented that model. It's just a new delivery of how you provide health services. We have implemented, in our pilot site was Salina, and Salina's been very successful in implementing that. All of our health indicators, measurable outcomes, have went up except one. We are the best of all the pilot sites. We are starting the implementation in our other facilities, and we have a 5-year plan to totally implement it in all of our facilities by the end of 5 years. And it's basically, in short, what it is it's care that's delivered by a team of health professionals, and the design process for that is, for lack of a better word, pods. So you build a pod here that has the whole team, and then a pod here, and how many ever teams you have. And that's how you design it. So we want to design Bonita so that it's conducive to that delivery of health care. And we've actually had to recently do some renovations at Salina to get Salina where they're now can operate in those healthcare teams well.
Melissa, you may also mention, we actually have somebody on that committee.
Yeah, there's a committee that is just on the design of healthcare facilities for patient-centered care, and we have a representative on that national committee, and their purpose is to develop guidelines for design for healthcare facilities to deliver patient-centered care.
Councilor Fishing Hawk.
On this plan, are these prioritized?
No.
They're not?
No.
Councilor Hoskin.
If we don't pass this resolution, what's the consequence if we reject it?
Well, for me, okay, the reason that I want your support of this is so that I'm comfortable in going out and doing all of these planning activities for all of these. It costs me to do a POR and a PJD for every project. We can do a lot of the planning internally, but actually producing the project, we have to buy those services back from Marjorie, and it costs to do that. So I'm going to have to expend some financial, and more than financial, some very human resource time in doing all of these things. And I'm, much comfortably doing that if I have a capital improvement plan that has been endorsed.
But if the resolution had never been brought forward for our consideration and the capital improvement plan's in place, I assume you had plans to go forward, and you've been going forward on the plan all along, right? So I'm having trouble seeing how the resolution, apart from comfort level, what it does for you.
Well, it does what I just said. It gives me that assurance or that support that this is, the direction I'm going in. I think we've had lots of discussion over the last few months about this facility and that facility, and, Speaker Fraley every month asks me about Salina Dental, and I keep assuring her it's on the plan. And, I think once she said, I really want to see your plan. And so this is, my capital improvement plan. Here it is. And I would like for you all to support it.
If the plan changes in any material way as far as the administration is concerned, if one of these on the master table here just for whatever reason, we can't see into the future too far, but if the administration determines it's not warranted, the resolution doesn't obligate you to come back to us. In fact, you could just continue on if you wanted to. And just make
Well,
those
I
changes.
hope that I've demonstrated that, you
Let me
know.
withdraw that and rephrase it. What if you strike at rich tomorrow and we unfortunately don't have Melissa Gower anymore because she's taking.
I would be gone.
Or you know what I'm saying? I mean, we as much as we like to plan for people, we got to plan for our system. And I just get concerned that down the road, somebody who maybe we've got much less experience and much less reason to have faith in steps in and says, well, we're going to change X, Y, and Z. But the resolution doesn't bind your successor in any way, or you.
That's absolutely correct. I mean, I think we all know the definition of a resolution, and it is a resolution of support. Absolutely.
Would you agree? Look at the master table. Just look at those first two columns. It says name, it says city. There's a whole list. And that's the whole list that we're talking about. Forget all the details. Forget all the numbers. Just the first two columns, name and city. The council could pass an act which says we'll establish these clinics, and we could essentially restate those two columns. Is there anything objectionable about, rather than a resolution, the council passing an act which says these will be the clinics? Forget the fine details and even forget the cost projections, which are right here, but forget those. I mean, what is objectionable about an act, if anything?
Well, I mean, to me, what I'm asking you to do is to pass a resolution of support on the plan so that I can start moving forward on the planning process, so that I'm very comfortable in moving forward on the planning process. Let me rephrase that. What I would do is I will be coming back as we complete the planning process on these, and bringing back a plan that says I've just finished turning in the environmental review and the documents and signing a joint venture agreement for Veneta. I'm working on financing for that and continue to give you updates. If I go into that process and, the worst case scenario is something happens and I can't get financing for Veneta, and I have to not be able to do a joint venture for Veneta, we have a problem. If I go into J, I have plans on what I'm going to do for J. I'm going to apply for another joint venture for J because I want them to have a bigger facility, not a replacement facility. So I just think there are lots of things throughout the whole planning process that can happen. I don't plan on that happening, but it can happen. And so that's why I just wanted a resolution with support of the current plan, and as things are changing through there, of course I'll keep you updated on those on a monthly basis as I continue to try to do, and that would be my preference.
And those are all excellent points because we can't see into the future. If something dramatic changes, I don't like your example about Veneta, but I'll use it anyway.
But since you and I were talking.
Dramatic changes that, a plan has to be scrapped. If it's in a resolution form, there's really not much pressure on the administration to come back to the council. If it's an act, you got to make a difficult decision. You got to say, well, that funding source fell through. I better get back to the council and say the funding source fell through, but we know we're obligated by law to do this. So unless you change the law, we need to talk about how to find an alternative funding source. I mean, from my perspective as a member of this body, I'd much rather put the pressure on the administration to have to come back and ask for a change in the law than to leave it completely within this administration or future administration's discretion. So that's my long-winded way, I suppose, Mr. Chairman, of saying that my preference is a legislative act. I fully support the resolution. I'm going to vote for it. I'm not on the committee, but I'm going to vote for it when it gets to full council. But that's my reason that I think this ought to be in law in some form. And I understand from where you're sitting, if I was standing where you are, I'd probably have a different perspective. And I would want more freedom of discretion. And I don't begrudge you one bit for that, because you're the one that has to do this difficult planning. But from where we're sitting, we have to go back home and tell our constituents, well, the health care plan's moving along. I think we want something a little more sound than a resolution. At least that's my preference. But I do support this, and I appreciate your hard work. Thank you.
I want to interject a comment, and you still have the floor if you want to rebuttal. I think Councilor Hoskin knows how much I respect his opinion on a lot of things, and I see this as a fundamental difference in ideology. I am a firm believer, and I have said this over the year that I've been on the council, that politicians don't need to run businesses. I truly believe that. And the fundamental difference in ideology, I think you made some eloquent points last night that I completely agreed with. But for me, it boils down to that fundamental difference in ideology is an act so subtly crosses that line into politicians running businesses. A resolution doesn't. And for me, that is really the tipping point. So you still have the floor. So.
Well, I appreciate that, and there is this difference in ideology, and I appreciate that. But go to the United States Congress and go look at the law that established the Claremore Indian Hospital and the Hastings. In fact, even our report talks about a congressman that championed that. It was Congress that has established these federal facilities. It's the state of Oklahoma that's established state facilities. There is a difference, and I do respect that difference, and it's a legitimate point, but I just think that we ought to be standing up for putting these into law, leaving those details to the administration, but Congress does it, the states do it, and Cherokee Nation Council ought to do it. But I do respect your difference of opinion.
Councilman Thornton.
Yes, Melissa, I'm not here to try to run your business, but I do kind of like to get down to the nuts and bolts of this deal. And as your cost per unit, what does that include?
It's an estimate on the cost per square foot to build a healthcare facility.
Then this goes from like $150 per square foot to 300 or somewhere in that nature. Your furniture and equipment and your land that you're going to have to purchase.
It doesn't include land.
It doesn't include any.
It's construction and furniture and equipment.
It does include that.
It does.
Okay. On the total cost, how about federal grants? Does it include any of those? Are we getting anything to help do this?
Well, I don't have a financing plan for any of it. Total cost is just the projected of what it's going to cost based on these estimates.
Well, is there any money out there to help build these facilities?
Well, I think, over on your funding source is where I worked on the projection of the of one possible avenue of funding. From space costs for the warehouse space and for the program space. We can do third-party revenue. We can issue healthcare bonds like we just did, but the third-party revenue has to be new revenue that's not already accounted for in our system. So the surgery center is joint venture with Cherokee Nation businesses, Tahlequah City Hospital. As you know, on Jack Brown, about 3 years ago, we finally got them approval to start billing, so we're collecting third-party revenue there. That's new revenue that's not already been obligated. Salina Dental would be new revenue because it's a new service that we've not offered there before. Bonita Clinic is going to be a new revenue because it'll be going from a small nurse practitioner clinic to a comprehensive healthcare center. Jay, I hope to be able to do another joint venture for Jay. So, I mean, yeah, there are opportunities for funding sources for these facilities. And, you know, what I've always done in my career here at Cherokee Nation is that I try to find all those sources and take those forward. I very seldom go to Callie and say, you know, I just don't have any money to do this. We always try to develop a scenario for funding any healthcare facility that we build internally.
And we're talking about third-party and discretionary funding.
We're talking
General
about,
funds.
pardon?
General funds, discretionary funding and general funds, is that what you're talking
Well, I haven't listed general fund on here for anything. It's not to say that, you know, I won't need some, but on here it's not listed as a source currently. And I just won't know what those scenarios are until I get to the financing plan stage.
Okay, thank you.
Councilor Fishing.
Yeah, I'm curious, where do you think Salina Dental Clinic would lie on this plan?
I think it falls, that we're going to start the planning this year.
Can you?
I mean, this year, I can give you an estimate of what I think.
Okay.
Or what I plan on doing is that for of course, the surgery center is already ongoing. That's in the process with CMB. So that one, that one's now. It's been going on for a while. Jack Brown, Salina Dental, and Bonita is another one that's regulated by joint venture, and we continue to move forward on that. But Salina Dental, Jack Brown, and Hastings property, I'd like to start the planning on now. The only one that leaves is Jay, and Jay, I want to apply for a joint venture as soon as the applications come out.
Okay. And you talked about starting Hastings this year.
The planning, yes.
Last night at the council, I talked about the health programs, the offices, eating up roughly a third of the total cost for the Burchett property, and taking up, out of all of it, it's going to take up the most square feet. I'm taking it's your admin offices maybe?
Okay.
Am I looking at that right?
Well, the plan would be this. Currently, for that building, currently health services is spread out all over Tahlequah. We have now very little space in the complex because we've been moved out of the complex. There's about, I don't know, 10 or 15 of us remaining in the complex, and that's it. So the rest of us has moved out. We have both dorms at Marcoma. We have 2 huge offices on 4th Street that we rent. We have half of the strip mall behind Reeser's that we rent. So we're spread out all over Tahlequah. The cancer program, diabetes program, QI program, our finance, billing, and budget program, all of our behavioral health offices, our ATR office, and then just the administrative office. So those offices, we're already paying either space cost to the tribe or lease cost to an individual that we're leasing space off of. So the plan was that we would build a facility on that property to house all of those health programs, so that we're all in one place, and then and we already have the money to pay for that service because we're already paying it. Then another portion of that would be space that we would be able to move non-medical programs out of Hastings into. So it's possible we could move the administrative staff out, the billing staff, the WIC staff, the maybe contract health staff, I'm not sure what all, I haven't identified all those programs, we'll do that through the planning process, but that's what that building would be for.
Didn't we just now get this spending about $1 million in redoing your health facilities over there?
What health, I don't know what you're talking about, health facility.
How much did we spend redoing Marcoma?
I have no idea. I didn't do Marcoma, the tribal facilities.
And that's where you moved to?
Well, health moved into the two boys' dorm, the boys' dorm and the girls' dorm. The girls' dorm finances all of our financial, billing, contract health services staff. The boys' dorm houses WIC and Healthy Nations program.
Okay, last night at the council, I brought this up about how much we're going to be spending on your offices and admin that's not going to the people. And it was pointed out to me by the chief that building the health programs offices was half as much per square foot as building clinic fees. But I'm looking at the square foot size, and you just now told us to take into consideration furniture and equipment is included in this amount, and the outpatient clinic is showing up at $275 per square foot, and health programs, which is the offices, is showing up at $250 per square foot, which is a $25 difference, which doesn't equate to half by any means. And I'm keeping in mind furniture and equipment's added on here, and desks and chairs versus equipment for a clinic, there should be a heck of a difference. So I'm kind of confused about that. Can you talk to that?
You'll have to talk to the chief about that. I have no idea. I was not there last night, so I don't know what he said.
Okay. Thank you.
Councilor Jordan?
Melissa, where you moved, you said was the boys' dorm and the girls' dorm,
Yes.
right?
Mm-hmm.
So the total cost of renovation by the amounts that we were given yesterday from Mr. Campbell's office, I believe Mr. Farmer.
Okay,
is the
that'd be
new
correct.
facility
That's correct,
person,
he is.
is approaching $2 million.
Okay. And
As I recall, the land out at Marcoma, when we bought that, ran like $1,100–1,200 an acre. And I know this is probably not your area, but it made a lot more sense to me to consolidate all of health on Marcoma's property, since y'all have never been close to the clinics or the hospitals anyway, to consolidate all of your health activities there on land that costs somewhere between $1,100 and $1,200, and that we've already renovated a good portion of at $86 to $89 per square foot, versus putting you at the property on the 45 acres that was bought by the tribe, which I think, and correct me if I'm wrong, ran somewhere in the neighborhood of $20,000 an acre, $18,000 to $20,000 an acre, and is going to cost per unit foot $250 to build facilities for you. And I think that was the point that Councilor Fishinghawk was trying to make. Would we not be better to utilize the more reasonable land for the office space and the higher land for those actual direct activities concerning inpatients and outpatients there at Hastings?
Okay. I can address part of that, okay, because I don't know anything about all those figures and stuff. But
I apologize, I just sprung this on you, but we got this information yesterday.
One is that what has been renovated at Marcoma is the two dorms, and those are full with health staff now. Okay, so they're full. So I would assume that if you wanted to take all the rest of health programs that are spread out all over Tahlequah and consolidate them on Marcoma, there would have to be space available there at Marcoma to do that. So that would be an issue that I have no idea about.
I think we have 119 acres there, so that probably would be sufficient acreage to spread.
But I mean facility-wise, there's going to have to be a facility
we
or
have
space or
21,000
something.
more square footage in the other facilities there that are not committed right now.
That's not renovated or committed. Right. And I don't have any cost on that stuff. That would be Mr. Farmer. I don't know what it would cost to get that square footage ready for occupancy. Is I guess what I was trying to say. And then secondly,
Between
is
$86 and $89 a square foot.
okay, I don't know. And the second point is that the reason that one of the principles of why I thought, or we in health thought, it would be good to co-locate all of us on that facility is because that is then the main health complex to run all of those programs and coordinate out of. And I think that, I mean, it seems to me in the planning that we've already gone through with the site that there's plenty of acreage there to do all of these things. So I don't think we'd be taking away acreage for, that could be used for a direct care facility. And some of the programs I'm talking about are direct care programs. ATR is a direct care program, behavioral health is a direct care program, cancer programs, diabetes programs. The only programs that aren't direct care are finance, billing, and of course my office, which is 5 people or something. And the QI program.
But Melissa, do you see our concern that we have high price land versus more reasonable price land? Which one do you want to put office space on? Do you not want to reserve the land that might be located next to a clinic and hospital for other future facilities that will have a direct relationship to an inpatient or outpatient need versus office space, which could be located on a piece of land that is more reasonable in value and still within 5 minutes to 10 minutes of where you need to be if you need to go up to the Hastings, what we'll call the Hastings complex.
Councilor Jordan, I've got some other people waiting. Is there going to be a question or amendment or?
Well, this is a concern in the plan. If the master plan is to build 60,000 square feet at Hastings, my question is it not better to relocate that office space somewhere else? If we're going to put our stamp of approval on the plan, and that's what I'm asking.
Is there going to be
would you not consider that it might be more reasonable to relocate that on the 119 acres that we have available out at Marcoma for no other reason? It didn't cost us as much per acre. It's like 1/10, and that's my question.
I don't have the answer to that. I don't know that because I don't know anything about the numbers you're talking about.
Check into that.
Yeah, and I think that Mr. Farmer would be. He knows more about tribal-wide facilities and acreage and all that kind of thing. So you also might.
Until 2 o'clock.
We have a motion on the floor to recess until 2 o'clock. And who seconded?
Discussion.
Okay. Did we have a second?
I did.
Okay, we have a first and second. Go ahead.
I'm noting a concern from Melissa that she might not be able to be here.
Yeah, it'll be very difficult for me to be here at 2 o'clock. My day is booked today, and we have the grand opening, and
might I make a suggestion that we continue and just move everything that we had a little bit later in the day? As we finish this, we move to the next one.
Here's.
Move the table. Second.
We have a motion on the floor to table and a second.
Call the question.
And it's been called.
Point of order, what are we tabling? Her motion or the whole thing, or?
My motion, which is the whole agenda item.
We're tabling the motion and the friendly amendment that's on that motion.
Call the question.
Question's been called. All those in favor?
Aye.
Any opposed? Motion carries. So we tabled, correct?
So I'm going to be tabling it, Mr. Chairman.
I didn't hear you, I'm sorry.
How long are we tabling this?
We're not reading,
Until next month.
until next month.
If you don't table it to a time certain, it has to come back. I mean, you either table it to a time certain, or it's tabled, it goes to the table and it can't come off. One or the other.
This was the problem, if I may,
Please.
that if there were friendly amendments that were going to be offered, the person who made the motion needed to be here to accept them. The discussion was carrying out so long, we weren't hearing, she wasn't hearing any amendments, only questions, and she had an appointment believing that this meeting was going to end at 11 o'clock. It's now 11:40, and so that was the problem. I don't know at this time.
Mr. Baker?
That being the question, true, she needed to be here for any friendly amendments,
I think she just interrupted her.
but that wouldn't keep us from making amendments and just voting on each amendment. And being I'm the only one that voted against it, or not the only one, but one that didn't, I would make a motion to bring it back off the table so that we can discuss it and finish it today. That's my motion.
Motion's been made to bring it off the table. And I'm going to need a point of order here. The individual that holds the motion, do they not have to be in the room?
Yes.
They do not.
Is Todd Embry here? I do not know the answer to that question.
If there are going to be amendments to her motion, then does she not need
I would
to be
assume
here?
that she would need to
Only
be in the room.
friendlies.
Only friendlies.
Only friendlies.
We can vote each time.
Madam Speaker.
Mr. Chairman, Ms. Gower needs to leave by 1, so that helps any.
I mean, I don't think anything's cutting down anybody's throat. It's just
Councilor
it's a
Hosmer.
question.
I just wanted some clarification. If we were tabling the entire resolution, the question was whether it was to a date certain or just tabled indefinitely.
My understanding was, my assumption was to the next health meeting next month.
Does that pose, maybe I'm out of order to even ask this, does that pose a problem in terms of the Gower, in terms of the...
Can you address that? Does tabling this till next month pose a problem?
30 days. I mean, it's, just 30 days longer.
What specifically would be held up as a result of not passing? And I don't mean to put you on the spot, but I mean, I actually think the resolution, pass or fail, probably won't impact it, but I know you say it will, but I don't want to put you in harm's way.
Well, for example, I probably, if it's going to be on the agenda again next month, between now and then, I probably won't go enter into some obligations that's going to obligate me for some money to start a POR and PJD for any of these projects. I mean, that'd be one example. I just wouldn't obligate myself.
Which still brings me back to the original
At that
question.
point in time.
I do not know whether we can bring something off the table without the individual that holds the motion
I think you
not in the room. I do not know that.
Only the ones that vote against you can't get, you were there, that would be the only thing.
You could rule and
No,
we
but
overrule.
only the two that voted against it.
That's from
No,
well.
they're the only ones that's allowed to bring it back, because we've gone through this before, haven't we, Joe?
Rule says you can vote on the
But, yeah. Well, yeah, you can still make amendments. They just can't be friendly if you can't accept them.
I'm going to take
can make a motion anytime, get up and leave the room, and be done with it. Never even vote on it.
Waiting on the speaker to come back.
Am I correct in saying only you and Meredith now can bring it off the table?
If we're the only two that voted no. Yeah. The opposing deal is the only one that bring it off the table.
Hey, where are you? This is Shelley.
Is this kind of like get your ball in the hole?
Shelley.
I guess, I don't know.
We looked at this with the manager, remember the paper?
I've got Todd on the phone.
Yeah,
Here's Brad, hold on.
I don't think she was thinking.
Todd. We have a motion and a second on the floor on a resolution. And there was a friendly amendment accepted during discussion. The individual that holds the motion on the floor is no longer in the room. It was voted on to table. It was tabled. One of the issues on the tabling is it was not tabled to a specific time. So the individual that holds the motion on the floor and voted during the tabling is no longer in the room, nor will they be back. One of the individuals that, there were 2 no's on that vote. One of the individuals voted to bring it back off the table. The individual that holds the original motion is not in the room. Can we bring it off the table without the individual that holds the original motion? Can we bring it back off the table, discuss and vote without them being in the room? The resolution. No. The person that moved for approval.
He's at a track meet. You hear kids screaming in the background.
I knew where he was. That is late.
No. Just bring it back off the table and get it voted on. But the individual that holds the motion is not in the room anymore. No, the person that originally moved to move for approval is not in the room.
What did it say?
What's it say?
Majority.
Well, yeah, the majority has to bring it off the table, off the floor.
Says anyone can
Yes, me.
bring it off the table.
Really? It's a special act on that one.
No, I would rather go ahead and do it. Well, then, when you go to a vote, what happens when the individual that originally made the motion to approve is not in the room? They hold the motion. Well, there was a friendly amendment that was accepted by that individual before they left the room. So if there are amendments after it's brought off the table and there are amendments at that point, what happens? By who? That's what I want to know. Okay. All right. Okay. That's what I want to know. Thanks. Bye. Is your motion still on to move it off the table? We had a motion to bring this off the table, and I believe there was a second. Is that correct?
Secretary. I don't have a second.
Second.
We have a second. Motion's been made to bring this resolution off the table, and it has been seconded. All those in favor?
Aye.
Any opposed?
Aye.
Roll call, please. All those in favor of bringing this item off the table signify by saying aye.
Harley Buzzard.
No.
Julia Coates.
No.
Bradley Cobb.
Yes.
Joe Crittenden.
Yes.
Jody Fishinghawk.
Yes.
Meredith Fraley.
Yes.
Janelle Fulbright.
No.
Don Garvin.
No.
Chuck Hoskin Jr.
Yes.
China Glory Jordan.
Yes.
Curtis Snell.
No.
Chris Soap.
No.
David Thornton.
Yes.
Kara Callan Watts. Buell Anglin.
No.
Bill John Baker.
Yes.
Jack Baker.
No.
That's 8.
Yes. Do I have any say in that?
Oh, that,
All right. That's tabled until the next health meeting. Next, I hope everybody will at least give a few minutes to Rick Richards, a presentation overview of Cherokee Nation Home Health. I know he's waited a long time, and this is an extremely important program, and he's done an extremely good job with it. And I hope you'll give him some attention, please.
Thank you very much. Got a little handout here for everyone. We'll just be talking off the top page. We got some information in our covers here that you can take home and look at it another time. While we're handing those out, Harley had talked a little bit about the PACE program and about how hard it is to get in. And about 4 or 5 years ago, I had the opportunity to have an open heart surgery, and the surgeon put a ring in my heart. And it took me less time to get admitted to the hospital for that heart surgery than it does for patients to get on our home health today. So the number of questions and the degree of detail that our nurses get into with patients is extraordinary. But if you appreciate kind of what our nurses are doing in those homes, you'd understand that process. What I want to do is give you a brief overview of the programs that we currently provide, and then talk briefly about some of our future plans and where we hope to go in the future with long-term care and extended care for the Cherokee community.
He called me on the phone.
All right. Does everyone have a packet now? Basically, where I'd like to start is with our hospice programs. It's under the Cherokee seal on the paper you have. One of the main things, or many things that all the programs that we do in the home have in common, is skilled nursing care. And in the hospice program, that is end-of-life care. It's Medicare benefit right now. It's a benefit under a lot of health insurance plans, and it's mostly the goal of this program is to provide palliative or comfort care at the end of life. It helps people manage pain. We work with the families. We have clergy that works with families under this program social workers, and home health aides. Primarily, our service area for our hospice program is roughly a 50-mile circle around Hallowell. We keep that geographic area fairly close so we can respond in emergencies. We respond 24/7, 7 days a week to patients' needs in the home. And what we would be able to do would be deliver medicines, medical equipment, or a nurse or a clergy would go to that home at night or any time during the week. So that's one reason we keep our service area fairly small for hospice. In the hospice benefit, the state of Oklahoma currently doesn't have just an open Medicaid plan for that benefit, but through the Advantage program, which is a Medicaid waiver program, there is a hospice benefit, and we plan on applying for that contract in the near future. Roughly, our hospice program has been in business now for about 8 years. Another program is our Advantage waiver program. We've been in business with that program since 1996, and that's the program that's more like, in some ways, similar to PACE. As you've heard a lot about PACE, the Advantage waiver, anyone who's on this waiver program, if they're over 55 years of age, would automatically qualify for the PACE benefit. They've been through the UCAT that Melissa mentioned. They've also been through the health screenings, the financial certification by DHS, and those type of things. That's quite a process to get someone on that program. If you need it today and DHS begin to certify you, it takes from 3 to 6 weeks. So it is a process to get into long-term care. We do case management in that program. With case management, there's a nurse or a trained manager assigned to every client, and their job is to see that that individual receives all services needed to stay safely in the home. If you could imagine a nurse working with you individually, seeing that you had all your medicines you need, seeing that you were taking them on time, nutrition and hydration issues. DME is part of the Advantage program, nurse aides, skilled care, coordinating those services, trying to help that individual get to and from the doctor. So all those duties fall on the case manager. We typically bill Medicaid for all those services. Sometimes we do see a veteran come through. We have a VA contract, and we'll provide some services similar to those to the veterans through a VA contract that we hold. That's our largest program by patient numbers. We cover 10 counties currently in the Cherokee Nation. We just expanded to Craig and Ottawa County this last year. So we're looking forward to some growth in that area. Currently, that program serves about 400 people at any given day, 7 days a week. Our oldest department is our home health department. It was started by the council in 1981. That department sees the most ups and downs because of the Medicare guidelines. We do provide skilled nursing, IV therapy, wound care. We have purchased some wound care apparatuses. One is known as Microvos. It's a real intense electrotherapy that stimulates the tissue that helps wound healing. The other is called the anodyne therapy machine, which is more of an infrared light that helps, again, increase blood flow for healing, and we use other techniques. Physical therapists and speech therapists are also included in this program. We have several speech therapists who work with us, as well as physical therapists, and our home health aid group. What we've attempted to do in the last few years with all these programs is really go above and beyond what Medicare and Medicaid require and provide a higher level of care for all of our clients. We've really invested heavily in training on our nurses and aides and office staff so we can respond to pretty much the market stresses that we go through with our competition. We do compete directly with all other agencies in this area. So what we're trying to do is keep our costs down so that we can provide additional care to our patients. So in short, those are currently the 3 services that we do offer, all under different license through the state. We are subject to state surveys on occasion, and so I'd like to say our home health department has 8 years of operation with no deficiencies from the state, as our hospice department. So we managed to stay in good compliance with those departments. Any questions so far?
Councilor Sugg.
What's the staffing levels, and you may have said this, maybe not very, for the home health, are you fully staffed, and is everybody fully utilized, or is there some growth opportunities there?
We do try to always maintain some capacity for growth. We typically don't assign our nurses as high as caseload as some other agencies, so they can give more attention to detail for our patients. So we have some capacity.
And then also, Mr. Richard, are you payroll certified?
We've never went through that process since we're 100% owned by the tribe, and so we never have went through that process.
What about your relationships with the various IHS facilities? As people go to the doctor and they get prescribed certain treatment, or they get prescribed certain follow-up, and then do you contract with Hastings and Claremore Unit Hospital, or?
Typically, a Medicare or Medicaid eligible or even private insurance patient can choose their own home health care provider, and they work with the doctor at that facility, and if they choose us, then the doctor does the order, and we put together a plan for the doctor to approve.
Okay, so but when they like the contract health services, they don't really. How does that work?
Well, with contract health, that's through acute care and the tier system, I believe, for contract health.
So you don't have any participation in that whatsoever. You just get contacted by the patient, or do you get contacted directly by contract health?
Well, again, it would be probably more likely the doctor's nurse who would contact us for the patient, or the patient themselves when they come out of the hospital. Hastings, for instance, has a discharge planner, as does Claremore, and that discharge planner, after a hospital stay, typically contacts the home health through fax or by phone to give us the instructions.
How many people do you serve out of the Claremore Hospital?
Right now, very, very few.
Why do you think that is?
Part of it is what the chairman alluded to earlier for the hospital. There's a huge market pressure there. And the other part of it is we're only serving kind of the eastern side of their area, and we're attempting to hire nurses in that area, and it's real difficult to recruit staff up in the Claremore area. That's one reason, is that we just can't cover the entire area for them, so it's kind of difficult for them to make referrals directly.
Okay, but there is a need there, I guess, or an opportunity.
Well, there is an opportunity.
We just don't have enough staff, and that's why I was asking you, I guess, if you're fully staffed and you're carrying extra capacity,
well, then I can back up and say it this way. I got good capacity in Mays and eastern Rogers County area, but we're kind of venturing into Tulsa and Washington County, real sporadic. So I don't have capacity for the full 14 counties. Maybe that's the way to say it.
Okay. Thank you.
Any other questions?
Right ahead.
All right. Right now we have about 500. This year, for 2008, we've been averaging over 500 patients. Our census for this year, which was a new high for us. We are trying to expand more into Rogers and Tulsa County areas with our Advantage program and our Home Health Medicare program. So it's been real difficult. If you take time to open Tulsa World, which we do very, very often in our business, and on the health recruitment page, at any one time you'll see 200 to 300 nurse positions open. And to hire a staff member that understands the technical side of this business is pretty difficult, but we're working hard on that. The long-range plan that we want to do, that we've been looking at, is While we were building and looking at the PACE program, the Adult Day Center piece popped up at us. And another thing that kind of pops out at us a lot on Adult Day Health is in our Advantage Waiver area. It has a benefit that's really unique in that it has a respite benefit where a person can go to a nursing facility for a short stay and then go home. So with that respite benefit, the parents, in some cases parents are caring for older children who need home health care. In some cases older children are caring for parents who need health care. And so what we began to see was the need for a facility. And what we started looking at is looking at a facility in Jay, Oklahoma that has come on the market that we could purchase. And we've done a lot of feasibility studies and all that goes with that. And we've looked at this facility to begin to think of as a nursing facility in a whole new light. Rather than long-term care, begin thinking of a shorter stays, the 30, 60, 90-day stay, to do real rehab and intense work with individuals so that they could go home. So what we're looking at doing is purchasing this facility, which is a 98-bed facility, and adding an adult day health care component to that. And so another thing we're looking at, there's a concept that's been developed over the last 5 to 10 years in the long-term care industry called the greenhouse concept. And essentially what you do is you break up your building and you create cohort, or another word would be age-appropriate living areas. So you create communities within that area so people are more comfortable with that living environment. So that's what we're going to look at doing with the J facility. And once we add that component to what we're doing in any area of long-term care in the Delaware County area, we would be able to meet a health care need. So that's our future plans, is begin to look at adult day health center and facility type services in long-term care to work with our home and community component. So in short, that's kind of what we're doing, and that's kind of where we're headed in that area. And we're attempting to expand into Rogers and Tulsa County also. Any specific questions?
Councilman Buzzer.
I was going to make a comment, and Rick, correct me if I'm wrong on some of my figures here, but what we're looking at here in J is a facility that is already up and running. It's already making some money. I think it's grossed about $1.5 million a year. We're not looking at a facility that has zero income coming in. The other thing that we're looking at is everybody goes to the nursing home. Your plan is to go back home. And so we're looking at this as a rehabilitation center instead of a Cherokee Nation nursing home. And name it as a rehabilitation center and put that name on it and actually advertise that name as a rehab center. Right now at the J Clinic, we don't have any physical therapy people there. We talked about looking at this nursing home and get a physical therapist on staff and even utilizing some of that stuff from the clinics that could be done. So to me, this is a win-win situation, and if this works out here, and I'm not talking against the PACE program, but the PACE program, you've got a lot of money you've got to put in that thing and zero income coming in for the first 2 to 3 years. Here we have $1.5 million that's coming in already. I've looked at this facility. It's a nice, clean, fairly new facility. So I'm excited about the proposal that Rick has put together on the thing. So
the staff at the Monroe Manor, they've recently won a Quality of Life Award, pretty much the top 10% of the state for improved living in the facility. The real thing that you've got to, the hidden thing here that most of us don't know, and it even surprised me, the numbers. In the Delaware County area, there are 400 people on the Advantage program now. And that means those 400 people meet nursing facility level of care as designated by the state. We put together some specific numbers for that area, and our numbers indicate that under about 20% of those 400 people are under 55 years of age. We're serving a lot of 20 and 30-year-old individuals who have catastrophic health conditions, and at times their wounds or whatever's going on with that individual is very difficult to manage in the home for both, and I did allude to parents taking care of individuals. And if we can create a facility, a rehab center, where these young adults can come and feel comfortable for a 30 or 60-day stay, and then get that individual back into their home environment in a lot better shape, that's a very, very worthwhile and ambitious approach on our part. So with our home health components that we already have in the community and the capabilities at a rehab center for extended stay, we feel like we could improve the quality of life for a lot of individuals. And that's really what we want to do, is begin to bring these components together and start working in conjunction with each other. The staff at the facility, and Jay, they're very community oriented, and they're working hard to become what we're already talking about, a group of people that work diligently to help people return to their homes in the community. And what we would do is add a component to that, the Adult Day Health Center, which is a service that area of the county has never seen before. And that facility with its meal service and that type of thing to support that activity. All these activities would bill either Medicare or Medicaid for services rendered. So they'd be self-supported, much like our home health has been for about 10 years now.
Any more questions? Others?
Rick, is this something that we're going to look like we want to try to move on fairly quickly?
Yes, we've been in discussions with the owners of Monroe Manor for about 2 years now, and they've been real patient with us. We've put an offer on the table. We've done all our preliminary work, and we are in position to move forward with it as soon as possible.
No more. Rick, I appreciate it.
Thank you.
Councilor Jordan.
Yes, ma'am.
Rick, would you care to come Thursday night to Hobart Community Center and set up a little table and tell us what you could do for our elderly at Hobart?
Right where Hobart's at.
Okay. 5:30. We'll feed you hamburgers. Okay. Thank you.
Feel fine.
Okay.
Rick, I appreciate it.
Thank you.
Next are announcements. The only announcement that I foresee at this point, one more looks like, is there will be flu shots given on October the 23rd for the tribal council and the staff. That is the day that we come back to discuss the Delaware MOA. Councilor Coates.
That's at 12:30.
At 12:30, I'm sorry, 12:30, October 23rd, flu shots for tribal council and staff. Councilor Coates.
Mr. Chair, I would just like to propose that given the lateness of this meeting, the length of this meeting, and I know there's a working group that's going to meet right now, is that correct? That we push back the start time for the Education and Culture Committee to 1:30 this afternoon with everyone's approval, and that will give the group time to meet. It will give those who are not in the group time to get lunch, and just to notify our web stream watchers.
It's been, do you have a comment on that? Or?
Not on that.
I'm sorry?
Not on that.
It's been, is that a motion?
If it needs a motion, then I'll put it in.
I don't believe it does. It's been suggested that we move the next committee back. Did you say to 2?
1:30.
1:30? Is that in agreement with everyone? Anybody have any discussion on that? Okay, it will be moved to 1:30. Councilor Baker.
We'll try one more time to bring that health plan off the table for the purpose of passing it as amended with no amendments. That's one of the motions.
We have a motion on the floor to bring back the resolution endorsing the Cherokee National Health Capital Improvement Plan as written with the friendly amendment that was accepted by the person that originally held the motion. Do I have a second?
Second.
We have a first and a second. All those in favor of bringing it off the table as proposed, say aye.
Aye.
Aye. Any opposed? Aye. Roll call. Yes means you want to bring it off the table. Councilor Baker.
I have a question. Was that to bring it off the table with no discussion? And vote on it immediately?
Yeah, you just, no discussion, just vote on it as it has been friendly amended and accepted. That's the purpose of bringing it off the table, just so she can move forward.
But with no discussion?
But no discussion.
There is a motion on the floor to bring the resolution off the table. It has been seconded with the understanding that there is no discussion and it's accepted with the only friendly amendment.
It's only coming off the table to be voted on, period.
We're going to do roll call. All those in favor of that coming off the table with that stipulation? Yes, as you want to bring it off the table. No, as you do not.
Jody Fishing-Hawk,
Yes.
Meredith Fraley, Janelle Fulbright, Don Garvin.
No.
Chuck Hoskin Jr.,
Yes.
China Gloria Jordan,
Yes.
Curtis Snell,
No.
Chris Soap,
No.
David Thornton, Kara Cowan Watts, Buell England,
No.
Bill John Baker,
Yes.
Jack Baker,
No.
Harley Buzzard,
Yes.
Julia Coates,
No.
Bradley Cobb,
Yes.
Joe Crittenden.
Yes.
Seven yes and 6 no.
Move to approve as it has been amended.
Second.
There's a motion on the floor and has been seconded to approve as amended. All those in favor?
Aye.
Any opposed? Motion carries.
Right. Praise the Lord.
And I'll take it. We've got a motion to adjourn.
Second.
And first and second, all those in favor? Aye. Any opposed?
Well, let's,